This session is titled about managing metabolic emergencies in the context of being in a pediatric emergency medicine situation. You've got a baby with a metabolic emergency, and so yes, that is the sort of part of the planned outcome from this session, is to understand how to manage that situation. However, the risk of simplifying things by actually talking about the management of metabolic emergencies is that that's not how our job works, is it? We don't get to know as a child comes through the front door what is wrong with them. And that is never more true than it is when a baby presents to the pediatric emergency department or to your emergency department, wherever you are. The reality is that all the presentations that babies come with are basically non-specific. That they have an ability to have very vague signs and symptoms, and that we have to try and work out. So one of the things we're going to do first of all is explore how to manage that process of considering all the various possibilities, understanding what those possibilities are and how we manage them. So just to explain before we start the session, this is not just going to be about metabolic emergencies. In case you were expecting that, this is about understanding the baby who presents with vague, not very well symptoms, and then ultimately also understanding how you manage it when that turns out to be metabolic, which is a fairly rare occurrence. So for those who don't know me, welcome, and thanks for having me along. My name's Edward. I'm a consultant in pediatric emergency medicine. I work in the Norfolk and Norwich, having recently moved from Sheffield Children's Hospital. For those of you who are confused as to why I'm not there anymore, left there early this year, and I'm loving a life in the Norfolk Broads now. So nice to see you all. Got my Zoom drink. You'll never know what's in there. That's how that works. So the way I would like to do this session, as I say, I'm going to give you a little bit of context to what we're going to explore, and you're going to actually choose your own fate. You won't get to know what fate you're choosing. It will be chose blindly, but you're going to choose what's wrong with a child in a minute, and then you're going to get to have a little bit of a case description. And then you're going to go into some breakout rooms and discuss with your colleagues what you think is potentially wrong with that baby, and what you would like to do in order to explore that problem and to sort of decide what to do next. So I'm going to get you to do a lot of the work, really. So here we are in our emergency department, and what you've got here in front of you is, if you've been wondering, a Where's Wally jigsaw. So if any of you are working in pediatric emergency medicine and you haven't yet understood Where's Wally, then you haven't been doing your curriculum properly. Where's Wally is an essential part of pediatric emergency medicine training. It's a great little distraction tool when you're doing procedures or trying to get children to focus on something else. A Where's Wally picture book is absolutely fantastic. It very much maps to what we do. We get a lot of stuff come through, and our job is to try and find the significant problems, pick out amongst all of the noise, all of the distractions in our clinical practice, pick out those really interesting and complex cases that, like I say, are very often quite rare. And on a typical Where's Wally picture, you end up having lots of things that look like they might be Wally, because, as I say, in neonates in particular, presentations are non-specific. And trying to put the pieces of the jigsaw, because the information comes to us one bit at a time. So that's why a jigsaw is a most appropriate analogy, because even with a Where's Wally book, you get the whole picture all at once, and we don't get that. We get little strip teases, and then that is very relevant to the idea of this sort of pre-retrieval assessment and management, because One of the really tricky things in our roles is to decide at what point do we have enough information and have done enough diagnosis and enough management for it to be the right time to move, because too little and you won't know what's wrong with your patient having managed them properly. Too much and you spend too long. If you're planning on transporting a patient, that means that they need to be somewhere else. And if you do too much for too long, that delays definitive care. So that's one of the things that you can talk about as we go along as well. So here we go. So where's Wally? This is the character that we're looking for. For most of you, you will be familiar with Wally either from your own childhood or from your personal practice. So we've got a child coming into our emergency department, and there's going to be a variety of possible things wrong with them. They are going to have significant pathology, because otherwise this would be a very, very boring session. So you're going to see a poll launch on the screens now, and you're going to choose one of these 5 options. Just choose it randomly, any number, go for any one. And whatever the audience chooses is what's going to determine what the case is. So you're without realizing it, you are currently choosing what is wrong with the patient, because there are different possibilities. So I'll just let that run for another couple of seconds. And that will do very nicely, thank you. So by popular choice, we have patient number 3. So wouldn't you like to find out what patient number 3 is? So Catherine, sorry, your colleagues have chosen for you. It's already happened. This is the pace of life in emergency medicine, isn't it? Decisions already made before you get to work out how to do it. So this is our patient. In they come. This is a 3-week-old patient called Khaleesi, and this child has been brought by the parents because they're just not their normal self. They've just gone off today, and what I'm going to do is just put some very simple bits of information into the chat about this child, so that you've got that there for reference, and then you're going to go into a breakout room just to discuss that presentation. Say, so what I've got there is a 3-week-old who's just gone off a bit today. They're not febrile. This is anything that's not there, you can assume not to be true. And this is the information that you've got. You can have 5 minutes, which is enough time for you to have some introductions of the people in the room, find out who they are, what they do, and then chat through. So the things you want to come back understanding sort of amongst yourselves of what do you think the possible causes are, and how do you want to go about beginning that process of identifying what the possible problem is, and what do you think initial management would be, possibly thinking about things that you might do even before you've got a clear answer. That's how our job goes, isn't it? So Josie, if we could send everybody into breakout rooms now, that would be great.
Yeah.
When just to let people know. Nope.
Oh.
That's fine.
Oh, hi, Ed. They've already gone through to the rooms, I think.
No, that's all right. I forgot. I always give people a warning that when the breakout room is about to close, it always gives you that warning. Say, yeah, breakout rooms are about to close. And about 1 in 5 people always end up clicking the button that says leave by accident.
Oh, yeah.
So it's always worth warning people so that they get that final minute at the end. But damn it, forgot.
Okay, and it looks like everyone's got someone active in the breakout room so far.
Excellent. So not everybody has joined. If you haven't joined your breakout room and you can still hear me, then it is there should be a button on your screen saying join. So do join your breakout room and have that chat. Make the most of that opportunity. Good turnout.
Yeah, I'm glad to see. It was great. There's so many people.
Yeah, no, that's good. Good. Just flicking through the breakout room, see who I recognize. Did you set a time limit on breakout rooms, Josie?
I just have to close the room. It would be 10:15 would be 5 minutes. Do you want me to continue with the plan to close it at 10:15?
Yeah. Yeah, so a couple more minutes would be ideal, yeah.
Okay, so I'll close it at 10:15.
Actually, just hold on a second, Josie, because I'm just going to close these curtains behind me because I'm getting a bit of glare.
Okay.
And I'm back.
Okay, shall I close the rooms now?
Yeah, that'd be grand.
Okay.
And I mean, of course, we're going to consider about the
60-second countdown for them to leave now.
History, like antenatal history and those kind of things.
There we go. Some people back already. Other people will soon be joining us. Right, so yeah, I think we've got people back now. So just curious to see if it would be good to get people to put in the chat what kind of things that they were thinking about in terms of, feel free to post sort of pathologies that are kind of worst case scenario or general sort of categories of things that you want to consider, and put those things in the chat, see what people are putting. So somebody's saying sepsis. Oh my goodness, what made you think of sepsis first in a 3-week-old who wasn't quite right? Neonatal sepsis. So Rianne, you've put the misfits. Could you explain what you mean by that? Because I don't think everybody will know what misfits is. Are you able to unmute and
Yeah, just it's a useful mnemonic for the causes of a collapsed neonate.
Yep.
Pressure's on to name them all. I probably will not do that, but yeah, if you kind of Google it, it's really useful. Lots of useful tips there.
Excellent.
Sorry, what was it? I missed it.
So it starts with metabolic and ends with sepsis. Which is kind of an odd way round, isn't it? Which is that starts with the least likely possibility and ends with the most likely. But I guess a mnemonic that's going to prompt you to think of all the different possible causes is good to think about the less common to begin with. So yeah, thanks for suggesting that as a way of thinking. So cardiac, metabolic, respiratory, NAI, neurological. And all of these things. Somebody's obviously been sort of like a coiled spring there, Catherine, thinking of so things like congenital adrenal hyperplasia come into your metabolic presentation session. Go, yeah, try. Those shots to nothing. For those of you who are trainees, this is a little spoiler. I get kicked out of the magic circle for telling people things like this, but this is a good tip for when you're a consultant. Okay, so every now and then, early doors, just make a very specific diagnosis. Yeah, and what happens is that the 99% of the time that you're wrong as a consultant, people just forget about it. We'll go, of course, he couldn't possibly know what the diagnosis at that point, but it was just spitballing ideas, and they forget about it. This is all about how psychology works. But the one time that you were right, within 5 seconds of the patient arriving, you just go, oh, congenital adrenal hyperplasia. People will be like, that person is from the future. And then you get a reputation as a consultant of somebody who's just like, you're just clairvoyant with diagnosis. So if you just do it a few times, it's brilliant. Don't try it as a trainee, because then people will start to go, oh, this person's this person's a rogue. They're a dangerous trainee making diagnoses too early. You do it as a consultant, and people start to go, wow, that's incredible. So that's probably what Catherine is doing, just going straight in with the, yeah, this will be CAH. And if she turns out to be right, they'll be like, that was amazing. Kabuki said, love it. Oh, you get a few pediatricians in the room, they're like, let's come up with some really rare stuff. Okay, so there have been some suggestions about how we're going to actually explore those possibilities. What are the things, and I agree. So these are all great suggestions: sepsis, metabolic, NAI. We've had cardiac. We've had some specific thoughts. But at this point, we're still in a very vague situation, aren't we? So people have come up with some ideas of possibilities. So now let's talk a little bit more about how we're going to move forward. Somebody said check a blood sugar. Yep, definitely would agree with that. What else? What else would we want to do at this stage to try and get some clinical information, near patient testing maybe, or other things? So somebody wants a cap gas. Yeah, abdominal x-ray, urine. Okay. So still keep on. So ECG. Oh, somebody's asked for an ammonia. Okay. Again, I wonder how much that's influenced by the fact that we're here in a metabolic metabolic talk. Baseline bloods. Just get all the bloods done. Yeah, so the ammonia is a very specific thing for metabolic presentations to screen for that possibility. Okay, so you wanted a gas. Of course, you're going to want a gas with this floppy, not particularly well baby who's still breathing, still got signs of life, and was going to want to do this. So here we are. Here's Khaleesi's blood gas. So acidotic. Somebody says that's a worrying gas. Good, well spotted. Definitely acidotic, and we've got a high lactate, a base excess, a bicarb that's down a bit. Any other thoughts? So how is the? So let's say this is a venous gas when we put the cannula in. Yeah. Okay. Yeah, trying to make sense of it all. And anybody want to say? Okay, so somebody's okay. So lactate's really high. Lactate's really high. That's sort of drawn everybody's attention. And you know, but that still could be sepsis. So for those of you who are sort of in this session and thinking, well, the tests are going to give me the answer, the reality is that that's not entirely true. That they are still a process of getting clues and information, and that even the initial results are, as a rule, non-specific. Okay, so they are non-specific because anything that impairs your metabolism, and that can be infection or poor circulation, will affect your lactate. It's all about putting that jigsaw together. So let's look at this. So even things like ammonia, okay, just to throw a little spanner in the works, even things like ammonia can be affected by any illness, because if your liver is poorly perfused, you can get hyperamminemia. So even that is not as specific as people are sometimes led to believe. So let's look at this gas. They're acidotic. Yeah, they are. Yeah, respiration isn't sparkling, but it's it's there. Their lactate is significantly high. So interesting, their glucose is also high, on the high side. So it's a very non-specific picture, but in terms of, you know, what does that glucose have, kind of tells me that potentially there's a stress response. So I'm going to go back and say, on balance, there's somebody who said anion gap normal. Oh, somebody's getting clever there. So the anion gap being normal tells us that there probably aren't chemicals in the circulation that a gas won't tell us about, but that you can sort of see the shadows of it. That's what an anion gap is. It's the shadow of a funky chemical somewhere in the system that's pushing apart the anion cation sort of the maths of that equation. It's simple algebra, and when there's a big gap between those two numbers, it means often that there's so that can be a poison that's ingested, or a poison that your body's creating of its own. So in other words, either a poisoning intentional or accidental, or a metabolic cause. So people are saying, want more data, more information, more data. So in reality, you may not get more data. It may be that this is what we've got. So yes, we can ask about pregnancy and delivery. I can tell you for Khaleesi that they had an uncomplicated pregnancy and uncomplicated delivery, and that this is yeah, a non-specific presentation. So somebody's asking about ketones. Can I ask? So it's come up a few times. What do people think the ketone result will tell you? Anybody, if you want to unmute, by the way, if you're one of the ketone requesters, I'm always keen that when we ask for a test, you know, we're clear about what we're looking for with the result. Okay, so yes, the child's feeding less and being sick. So I would have said ketosis is probably going to happen because of the clinical picture, regardless of the underlying cause. Okay, and then suddenly, is the vomiting bilious? Of course, you would have known if it was, but yes, suddenly, now that you've asked the question, the child has another vomit and it is bilious. And that is because when you chose randomly, what you chose was that the underlying pathology was a malrotation of this child's gut, something that does happen in a 3-week-old and presents with a non-specific presentation, non-specific symptoms, and as you can see on this, non-specific results from the sort of the initial assessment. Yeah, so the answer is are the ketones going to be raised? The ketones would be raised in this situation. This child is not able to produce normal metabolism. So abnormal metabolism does not mean necessarily a metabolic problem. And that is one of the key sort of takeaway messages from this. Don't let anybody make it seem like this is an easy sort of there's a set piece for diagnosing metabolic problems. It is often the case that we need to consider and work through the probability rather than the certainty of 5 different significant pathologies. So the first one is always going to be sepsis. I would always consider a cardiac collapse or deterioration in a 3-week-old who's going off mysteriously. I would always want to consider the possibility that it's a surgical problem, that something has happened to the gut, and that the loss of circulation to the bowel is what's causing a deterioration in a child. The NAI is a really, really important one. It won't be overt. It won't present with clear signs very often. It will present with a baby who has, you know, sadly been shaken or injured in some other way, and who has damaged tissue. Often it's brain injury, and that they are presenting again with poor feeding, floppiness, whatever, and they will have raised lactate and a stress response, and everything will look very much like sepsis, but thinking about that possibility. And the final one is metabolic. Okay, so that's a sort of a first run through through that process of thinking about, well, let's assess this baby. So I agree with everything everybody's suggested so far in terms of possibilities, clinical approach, get information, get as much information as possible, go back to the child. I like that. That was there in the chat, you know, reassess this child, keep going back, have another look. We're waiting for this child to declare themselves in some ways. And that, you know, so it's great to be getting lots of tests done and waiting for those results to come back. And maybe they will suddenly give us a clear answer. Or maybe something clinical will change. Like this child, they had a bilious vomit. Surgical causes, it's not always a surgical cause of bilious vomiting in a child, but once that's happened, it has to be presumed. And if that is a midgut volvulus, like it is in this child, the only thing that's going to definitively treat that, of course, is surgical intervention. But in the meantime, guess what? All of your set piece interventions will be beneficial. If you look after ABC, maintain things like circulation, good oxygenation, good ventilation, good critical care management of this child, that is the best that they can possibly get, as long as we're moving them towards definitive surgical care as quickly as possible. Any questions about that before we go on to our next case? All right. So back to our 5 children. So I'm going to go on to the next case. And the next one is again going to be discussed by you in breakout rooms, 5 minutes. Use that opportunity to have a little chat through the things we discussed, maybe discuss some cases that sort of were relevant to you in your practice and how this is helping make sense of it possibly. Remember, if you do discuss a case, to do that in an anonymous way. I don't think breakout rooms are recorded, so that's all right from that point of view, but it's always just important to remember from a confidentiality point of view to be sort of as non-specific as possible when you're discussing cases in a meeting like this. I'll see you again in 5 minutes after you've had a chance to sort of talk through this. Okay, Josie, I'm just going to dash through assigning people who've dropped out of the meeting and joined back again, and I'm going to pop them into breakout rooms. So if you haven't been given a breakout room yet, don't worry, it's just about to happen. Just click on the button that says accept when it does pop up.
Yeah, so breakout rooms have been allocated.
That's all right. Yeah, so anybody who either joined late or dropped out and come back in again needs to be reallocated. That's what I was just doing.
Ah, great, thanks.
Somehow, yeah, Zoom does that. Even if you were in a breakout room before, if you drop out the meeting and rejoin, it doesn't automatically put you back in.
Yes.
Okay. So I've still got about 20 minutes. Is that right?
Yeah, that's right. And we've got coffee break 11 till 11:30 after that. So it's not too much of a press for time.
Okay. So if a vibrant discussion gets going.
Yeah, we can let it run a bit.
Yeah. And then at the end, I've got a just got a small number of learning outcomes. Do you want me to just put that in the chat, or do you want it in some other format? Do you want me to sort of send it?
Oh, whatever you prefer. Yeah, in the chat would be great. And if you had a document or anything, we could email it to everyone as well, if whatever you rather.
Right.
Yeah, I guess.
Mm-hmm. Josie, still there?
Yeah, still here. Yeah.
So I'm just going to say, while we're waiting for breakout rooms to finish, you know, we've got this plan for the, I think it was April.
Yes.
So I have completely had no response about getting space in the simulation training center.
Oh, that's interesting.
I don't know if you got any tips or tricks. I'm still learning how to navigate the systems locally, but I'm really struggling to get what would be useful in terms of a sort of a space to work. So I don't know if we need to think about doing it somewhere else, or.
I think I can speak to Matt. Matt is running the pediatric sim on I think it's the 26th. So he's managed to book, so I'll speak with him. The other thing is, if you wanted any pro sections, I can speak to Karina, because she's booked for the trauma team leader course there. She's booked wet labs as well, if you want a pro section station, and she's got access to the catalogs and things.
What's a pro section?
You know, like if we want to do skill stations, like with animal pro sections, so they've got larynx and chest and do and we've actually now got some funding. The crowdfunding is going well so far, so we might have a bit of funding to put forward for that one.
Lovely. Yeah, no, so any ideas you've got about how we can secure a bit of simulation training space would be great.
Yeah, I'll talk to Matt after today. And the other thing was, I know you said with dates in terms of the Easter holiday, which dates you prefer, because I won't get my April rota probably till March or February, but if we put a date in, then we can kind of ask other people if I end up not being able to get it off work or something, but I'm hoping I will.
Yeah. Super. All right.
I'll have a chat with you after.
Right. I've lost track of time. I don't know if it's.
Yeah, I think that would be 4 or 5 minutes we've been.
Yeah, I think so.
Should I close the rooms?
Yeah, go for it.
Okay, there's a 60-second countdown.
Okay, so it looks like we've just got the final bolus of attendees return. Love to see all your faces back again. So I hope that's been useful, sort of being able to talk to your colleagues. I can see at least one person in the meeting, Jessica Greelett, is that how you pronounce it? Has a Zoom mascot with you as well to join the breakout room. Hello. Hello. What's your name?
Lydia.
Lydia. Excellent. You may have other Zoom mascots hidden around the audience, children, cats, dogs, whatever. You're all very welcome. Makes it much more exciting to have these additional people along, as long as you are sworn to secrecy. Must not share any professional secrets. And another reason to sort of be mindful about what we say. So no swearing, anybody. We have actual children in the meeting.
Encouragement to get out of pajamas is very welcome.
So here we are again with I've tried to make these scenarios very much based on my own experience of these situations. Anybody who tells you that in retrospect it was obvious what the problem was, I think that's often unrealistic. That all of these presentations are non-specific. So just to emphasize that point, so we're dealing with probabilities, not certainties, in pediatric emergency medicine and acute pediatrics. So what we're faced with is this non-specific situation. So again, what sort of things you were thinking about? I'm guessing that people were talking about sort of similar possibilities. Was anybody confident about what the underlying cause was going to be here with this case? So honest unconfidence. It's not a word, is it? No, no, no. So the neurological effect was sort of thinking about people are going, he's floppy, he's not responding very well. Again, the difficulty with that, just to explore that, is really good for us to say, does that mean that this is an NAI? Does that mean that this child has a neurological problem? They've got a brain injury, or that they've got some of the sort of specific neurological cause? But of course, we've talked in the previous session about respiratory emergencies or ventilation emergencies and the metabolic requirements of a child. Now, when we're talking about metabolic requirements of a child, your body has organs that it's going to prioritize and deprioritize. The most sensitive end organ effect is always going to be neurological, because while the brain is the body's most important organ when it comes to preserving life, it's always going to do a lot of that. It does, within the brain, deprioritize higher functions. So as your metabolic disconnect engages, in other words, you're not producing the right amount of oxygen and sugar and clearing toxins at the rate that you need to be able to get your organs to work properly, your brain will deprioritize higher cortical functions. That's why you don't get a smile out of a child who's poorly perfused, dehydrated, hypoglycemic, whatever, but yet their brainstem functions work. You know, their heart will beat, their breathing will continue. So those higher functions reduce. So when we see those clinical signs, it doesn't necessarily mean a neurological primary cause, but secondary effect is quite possible as well. So I'm going to pull that rug right from under you and say, even the floppy, unresponsive baby, you just don't know at that point. So one of the very, very real learning outcomes from this is that you are going to be very, very unlikely in any circumstance with any presentation to early on be able to say, this is not sepsis, just on odds alone. And you will start to see that in practice, you know, so we start to suspect, maybe this could be one of those other four things: the surgical, the cardiac, the metabolic, the NAI. But you will see the experienced clinician cover for sepsis just on odds alone. And because of that non-specific thing, because it could just be that. So somebody, Jessica's saying, the other OBS and presentation looked relatively well preserved considering the extent of the neurology. Yes, I agree. No, I completely agree. So I look at that situation and I look at the I look at the clinical presentation and go, it doesn't feel like sepsis. Yeah, and I think that's valid to say, you know, as the experienced clinician in the room, say, this doesn't feel like sepsis. On odds alone, I think we should cover for it. You know, it's a brave or possibly, you know, we'll take a vote. Are you brave or foolhardy for not treating this child for sepsis when you're starting to consider that something else is probably happening? You're going to be called one of those two things in retrospect. And yes, because say foolhardy. Yeah, what's the cost for treating for sepsis? Risk, low. Risk of not treating, significant. Yeah, and the reality is that these are non-specific presentations. So treat it, and it's kind of like, okay, so let's go back to that idea that I've treated for sepsis, but I think it's important when you're doing that, this is a human factors thing, to tell everybody that you don't believe it. So one of the things I do in that situation, my top tip, because this focuses the people in the room, say, so I'm going to treat for sepsis, But I'm not convinced that's what the problem is here. I think we really need to look for other possible underlying causes. This doesn't really fit together very well. So people are saying, treat for sepsis, include acyclovir. This is a neurological abnormal presentation. We're concerned about herpes simplex virus. Increasingly, that's becoming common practice. And I think that the evidence for that as an effective intervention, we don't have it, but I certainly see that becoming more and more normal, treating with acyclovir for the non-specific neonatal presentation like this. So always ask about, was the floppiness new? Yes, so it is new. The child has had normal tone and normal activity, and that has gone off. So just looking at this again, very acidotic, very similar, with a very different sort of picture, and less of a lactic acidosis, more of a non-specific acidosis. The blood sugar, for those of you who are sort of more used to adulty blood sugars, that blood sugar is not just normal for a newborn, but actually pretty well within the normal range. So anything above, for a baby of this age, anything above 2.7 is generally accepted as normal, because their metabolism is slightly different still. So somebody said, oh, elevated, somebody's hot on their anion gap, so something's in there, something's not right, some chemical. And somebody sort of say, do you know what? I feel this is all adding up to a possible metabolic problem. So it's great, I think, that we're treating the sepsis, but I'm starting to think I'm quite concerned this. So we've taken our ammonia. That's a very pediatric metabolic test to do, but that's going to take some time. It needs to go very fresh to the lab, preferably chilled with some ice to keep it cool. And we're going to send a whole, so once you start to think this could be metabolic, what bloods do you want? Well, you want all your standard sepsis bloods, because that's still going to be something that we need to come back to. And part of the proving of metabolic problem is also about disproving the sepsis. The specific metabolic tests, things like gas, are very sort of part of a general workup. Specific metabolic tests, if anybody here in this session is worried, well, I don't know exactly what tests they need for a metabolic emergency, and I don't want to have to think about it when I'm in that situation. Okay, I completely get that. So there's a simple way of managing that. It is very likely that if sort of pediatric metabolic problems are not part of your comfort zone, that you can just you treat this child as the sickest patient in the hospital. Get your pediatric crash or emergency team, and when you take bloods, get an extra chemistry sample and a clotted sample. Take plenty of blood. Give it to the most senior pediatrician in the room and say, you do get your metabolic test done. That's fine. Or your trust might have a sort of a metabolic emergencies guideline to say what needs to be tested. And the final sort of retreat is to say, just take extra chemistry samples and send them to the labs marked as save sample for metabolic tests later. And that's also fine. In terms of tests, getting a urine as well. So the first urine sample that's available is really important. And then what we need to do in terms of the emergency management of a presumed metabolic presentation in a baby. It's all very similar, but ever so slightly different. So here are the finessing of this as a metabolic emergency. Okay. So the first thing to remember is shut down catabolism. Okay, so what that means is that their body's taking protein and fat and turning it into stuff is very likely to be the bit that's just going wrong. Okay. So the bit of their metabolism which is going wrong is almost certainly going to be their protein or fat metabolism. You can shut that down by not giving them milk and giving them sugar in a raw form. Yeah, so 10% dextrose. So the first intervention should be, it's very unlikely they're going to be taking a bottle, but somebody might be trying to feed them to comfort them, because, so stop the milk feed, give them a 2 mil per kilo, 10% dextrose bolus. That gives all their clever metabolic pathways a raw metabolite that has very little byproduct and just drives the metabolism onto a, yes, I've stopped my screen share because I'm finished with it, by the way. So puts them into a simple metabolic state and takes away the complex metabolic states that might be producing the poisons. And then immediately follow that with a maintenance fluid. Again, simple rules of thumb. 0.9% saline and 10% dextrose is a very safe fluid to be giving as maintenance fluid. They're going to be getting salt and sugar, and that's what they need for now. Simple stuff: water, salt, and sugar. Normal saline, 10% dextrose as a maintenance fluid. For those of you who are sort of going to take it to another level, when you're starting to sort of identify exactly what the underlying problem is, and start to treat it with clever metabolic drugs, I will mention for your benefit that the treatment of hyperamminemia, so if it turns out their ammonia is super high and we need to treat that, there's all sorts of drugs that are going to be given. And most of those will start with sodium something. So lots of sodium-based drugs that are given. Sodium benzoate, for example, is being mentioned there. Absolutely. And so it is often the case that it is worth changing the maintenance fluids to have, at that point, no sodium in, potassium and dextrose, but not sodium, because they're going to get a big sodium load from all the drugs that are going to treat the hyperamminemia. We're going to try and maintain not just normal glycemia for a newborn, but actually more adult levels of normal glycemia, because we really want to shut down that catabolic state. So although you as pediatricians will be used to saying blood sugar of 3 is fine in a 3-week-old, right here, right now, it's not. We want to drive that up. We want to keep it 4 or above, and really shut down those metabolic pathways. And to the extent that even if you're starting to achieve hyperglycemia, most would say at that point introduce a little bit of insulin infusion rather than reducing the glucose load. And that starts to get into the nuances of, well, if you ask different people, they'll have different thresholds for that. But that's it's a basic principle. Hyperglycemia is better than hypoglycemia by a long way in this situation. In terms of ventilation, as with any situation where we've got abnormal neurology, it may well be that we need to ventilate this patient. If we do that, we don't want to go for a low carbon dioxide, because alkalosis can worsen metabolic problems. So we want to really sort of, as much as we do with head injuries, we want that sweet spot of normal carbon dioxide levels. We want to really sort of nail that mid-range with carbon dioxide. Certainly don't overventilate, because if you blow that carbon dioxide down too much, it can really make things worse. And then the most important next thing, get in touch with the person in your trust or in your region who's going to be able to advise about specific metabolic treatments. Everyone should have a little collection of drugs, which is often called the metabolic box. So it's got a lot of the sort of specific clever drugs. A lot of them are just vitamins, by the way, clever sort of forms of vitamins, but they're ways of managing these metabolic problems. And so when you have that conversation with the metabolic consultant or pediatrician who's able to talk about specific managements, and they say, you need to give sodium benzoate, folinic acid, whatever, then you've got somewhere where those things can be found. So that's the specifics. So we're saying we think this is metabolic. That is just a moment. It's a decision that the person or people managing that child say, I think that we've reached the point where we think this is a possible or probable metabolic problem. And so what we want to do now is manage this with a higher sugar, absolute avoidance of protein and fat, and getting more information, but while also getting in touch with a metabolic consultant to discuss if there are any specific drugs that we need to give, and remembering that specific ventilation strategy of avoiding hypercarbia. So has anybody got any comments or questions?
There was just one extra question in the box. Have you got access to those? Can you see those?
Yeah, the lumbar puncture one.
Yeah.
So the question about lumbar puncture, I think that it's in everything that's going on here, it's not a priority, and the presentation is either going to be one where they're not so seriously unwell, in which case you're not sort of pressed into that being that urgent, and it can be done as sort of in good time as part of the workup, or they are very seriously unwell, in which case lumbar puncture is unlikely to be a good thing to do, because if they're clinically unstable in any way, lumbar puncture is quite a risky business in a 3-week-old who's going through the mill in terms of airway, breathing, and circulation. So often the answer is better to wait. So if you manage like this along your side, your sepsis treatment in a kid that ends up not being metabolic, will you do any harm? So this is, so somebody saying, maintaining a good glucose level is also important. And yes, so achieving normoglycemia and doing all those things. And that's one of the beauties of our approach to the non-specific presentation, which is what we do, which is that one of the reasons why it works so well is that most of what's in our set piece will work for all the different presentations. The difference is to do with definitive care. So, for example, definitive treatment of hyperammonemia is to remove the ammonia, and you can do things that will temporize that or do a little bit, good airway, breathing, and circulation. Of course, that helps, but ultimately they usually need hemofiltration, something to remove that high ammonia. So the specific managements obviously, depend on the underlying cause. We talked earlier about the surgical one, and that needs surgery. With the cardiac one, it may well be that they need prostaglandin. So there are specific things, but at the same time, all of the generic treatments are usually very beneficial across all the 5 presentations. There's very few where the situations where management of one would be making another one worse. So encephalopathy. So the reason why this is a floppy baby, the second case, would be encephalopathy. So it's essentially a poisoned brain. Yeah, so the aim is to diagnose and stabilize. And so to return to an earlier sort of thing that I mentioned, when you are in a situation where one of the questions is, do I move this child? This is always going to be a case of how far, we've seen how complicated this decision making is. how far down do you go in terms of getting an actual diagnosis? Because you could argue quite strongly that depending on what centre you work in, that one of the things to do is to begin a process, but move towards an early transfer with good management of ABC, because it's a dynamic business, and sometimes the initial diagnosis later changes. Like I say, what was thought to be initially a metabolic hyperammonemia can later turn out to be that they were septic, and it was their liver that made their poorly perfused liver that made their ammonia high. So yeah. Any other questions?